Ladies and gentlemen, welcome once more to the international webinar, Human Resources Management in Health Emergencies. It's sponsored by Ribeirão Preto's Nursing School of the University of São Paulo, a collaborating center of the Pan American Health Organization and the World Health Organization for the development of research in the field of nursing, in partnership with the Technical Unit of Health Systems, Services, and Human Skills for Health of the Pan American Health Organization, with its representation in Brazil and the Office of Management and Education in Healthcare of the Brazilian Ministry of Health. This event is being broadcasted by Ribeirão Preto's Nursing School channel on YouTube in Portuguese language, and also by the channel of the Innovation Portal website in Spanish. Today, we'll have the panel A entitled COVID-19 Pandemic, and to coordinate this panel, we invite Professor Dr. Pedro Fredemir Palha. Dr. Pedro Palha is a tenured professor of the Department of Maternal Infant Nursing and Public Health of Ribeirão Preto Nursing School, of which he's a deputy director during the term from 2018 to 2022. He teaches and researches on the themes of primary healthcare, health policies, management and organization of the health system, policy transfers, and tuberculosis. We inform the participants that they can send their questions to the speakers throughout the presentations via the chat available on Zoom and also on our YouTube channel. Professor Pedro Palha, the floor is yours.
Agradeço as palavras iniciais da senhora.
Thank you so much for your speech, Dr. Idamara. Morning, everyone. On behalf of Dr. Maria Elena Paguzzi, Director of the Nursing School of Ribeirão Preto, I send my compliments to everyone here and the preparation committee and the invitation to be here today. The second day of the event is entitled The Pandemic COVID-19. Yesterday, we had an excellent morning with guidelines, instructions, and reflections on human sources management in health emergencies. This morning, we have the pleasure to count with 4 speakers that will be here presenting today and shared with us their knowledge and their experiences on the theme. Each of the speakers shall have 30 minutes to present, as informed, to present their speeches. And when they have, and before 5 minutes to the end, I will turn on my camera to finish the presentation. We remind you that after the speeches, we'll have time for interaction and debate with the audience, with the speakers. I would also like to say and invite each and every one of you to ask your questions on the chat. To start our activities today, I will invite Professor Marcelo Marques de Lima. Marcelo is the manager and he's a specialist in project management and work management and education and health. He has a public administration degree from FGV, and he focuses on project development right now in the Department of Health, Department from the Ministry of Health, Brazil. Marcelo, the floor is yours. Thank you, Dr. Pedro. Morning, ladies and gentlemen. Once more, I'm here with you guys. I think this day will be very productive and we'll learn a lot today. So we'll have great debates. Considering that I have 30 minutes to present, I know that yesterday I had to leave early and people asked me 2 questions that I was able to reply on WhatsApp, but I want to take 2 or 3 minutes today to answer these questions. So I'm gonna just read the questions here. How was the update of Brasil Conta Comigo before it was ready for subscription? Well, the platform Brasil Conta Comigo is working. Whoever want to subscribe to it can do it. But anyhow, we have the database that I'll be presenting today, and it's significant and robust, this database. And we want to make use of this data. Of course, there is a database of self-declared data. So to any other purposes, we'll need an authorization of the users. Anyone who's interested in participating in SOS de Ponta program to be a voluntary for SUS can subscribe there on the website. And once we have updated the system, once it's online, we'll send the emails with the confirmation of the update and the status of the platform goals. And the second question was, out of this access, are they still up for subscriptions? Well, I think that this question is directed to access one of the presentation that I made yesterday, which is training for dealing with critical patients. This training will start on the northern region of Brazil, starting in April. And we have been preparing budgets. The tender process is being validated by the legal team so that we're able to publish it. And we're going to carry out this training in every Brazilian region, starting by the northern region. So every health worker will have the opportunity to try and get these vacancies. Now, I'll share my screen with you guys to start my presentation, okay? So today I was invited to talk about the experience of Brasil Conta Comigo strategy in this panel. So when tackling with the pandemic of COVID-19 in Brazil, so the strategy of Brasil Conta Comigo was an emergency action that we thought of as a response to the pandemic, an initial response to the pandemic. Up to a point, it was a desperate moment for us because we didn't have much information on how the virus worked. And there was this world crisis. So nowadays, even though we're still concerned with this virus, we have more information. So we deal with it a little bit better. So our structure was divided in 3 axes, which are directly related to human resources. So the health and labor management secretariat and the institutional relations that we have with CEGET, we thought of an axis that we would be able to work with students, college students, so with scholars, with the access of health workers that are already graduated but are undergoing specializations. And the third one with is Conta Comigo health workers, which is the platform. So the strategic action, Brasil Conta Comigo, the scholars. So it was the first one to be launched. Our goal was wrote down in different ways, but the goal was to optimize the availability of health services within SUS to contain the COVID-19 pandemic in an integrated way with health actions. So the goal was to integrate the program with school network and education networks and society. The target audience were graduation students in nursing, pharmacy, medicine, and physiotherapy. And another public audience were public health and private health establishments, and also ONGs. Why did we consider both of these public audiences? I'm going to explain it later. The legal framework is Ordinance 492 from March 23, which established this strategic action. And we also had this tender process, the first tender process from March 31 for subscribing within this action. And in what this action consists in, the idea was promoting a meeting between health establishments, which needed to replace their personnel, the students that were subscribing within this strategic action, and they were willing or interested in working with dealing with the pandemic in a multilateral platform with a matchmaking platform. So students would subscribe in this platform. Institutions would go submit their tender process, then we would analyze their profiles, and the public audience wouldn't be any students, just students that were undergoing the last 2 years of the med school, and students of the final 2 years of nursing and pharmacy. And now we carry out this mapping to determine at what extent a health institution was seeking to reduce the composition of their team. So we would seek the student that was closer to the unit we wanted, almost like a matchmaking website for meeting people that uses the logic of matchmaking. So the students had a workload which they could make use of as a mandatory internship if the institution will agree to that. So that was an agreement they could do with the institution. Now we have a distribution map. We have 112,959 students. Out of these 112, 2,799 were actually recruited. So they really acted tackling the pandemic within their own abilities. 1,022 institutions were present there. So they were present out of 1,022 institutions, and they subscribed to this program. Not all of them were approved in the program, but 3,659 health establishments were involved in this process. So we have an expectation of how much students we have inscribed and how much students were recruited. This information is from December 23rd last year, because we didn't have anyone new subscribing to the project until now. The second axis will be dealing with the residents from the health sector, with the goal of enhancing the cover for SUS users at all levels, especially when tackling with health emergencies due to the pandemic. So we were carrying out these actions and with residents from all areas, but we were given the opportunity to, actually he's correcting, he apologizes. All the residents that were informed by their respective institutions were contemplated, and they were informed by this strategic action. So the target audience of health workers that were undergoing residency programs in medicine and nursing as well. As for the legal framework, we have Ordinance 580 and Ordinance 2,654. Why the second one? Because the first one has this deadline, which was really short, for about 6 months, and the second one, Ordinance 2,654, created a strategic action to actually tackle the pandemic as an extraordinary legal framework. And the last payment was paid on January 2022, referring to the residents that were acting in December 2021. So in what does this action consist? So a monthly payment on the amount of 667 reais to all the active residents and health institutions, both private and public, without income. So we have 79 and 52 residents receive scholarships, there was an average of 52,813 residents receiving the scholarships per month. I believe that from 18 to 20 months out of the action, approximately 740 million reais were invested in it. So this section was really important, not only to tackle the pandemic, but also because we're struggling a little bit with the database on the internet, especially with health interns. I'm not saying anything new. I think that everyone who works with database, they know of this reality. This is nothing new. But the database of Brazil, we expect us to create a database that, even though we have a cutout in general, we're not talking about the entire population of every resident in the country. We're obviously not doing that. We're actually talking about 95 to 97% of these interns, because the internship programs of private institutions, they are quite small when compared with the residency program. So to strengthen the residency programs and to be able to support a projeto AGIR for mental health, Project AGIR to COVID 2020, it was a database that gave us a lot of support. We didn't use this database to anything rather than preparing public policies and getting to know the scenario, but we have databases that are more robust, which allowed us to establish actually a closer relationship with other institutions. So here we have this communication channel, thanks to this data that we were able to get from the strategic action. So I believe that the relationship got much closer, and we have a large opening we are able to listen to them more and to direct our efforts in a more structured and directed way. And strategic action Brasil Comigo for health workers. The goal, like I told yesterday, was to register and train health workers in health with clinical protocols from the Ministry of Health for tackling the COVID-19. So this database, it included more than 1 million professionals in it. We created the largest database for health workers, self-declared health workers in Brazil. Besides the cost that we were providing there, we carry out a very important work that Professor Alec is going to share with us of his research later on. So he participated in the training that were provided. We carried out in-person training in Manaus, training more than 300 health workers. And the action was developed for all health workers of higher education levels, and for the technical level, the nurses and radiologists. So we have a list of the health workers categories, and this was quite important because we got closer to the health committees, and they were quite solicit when sharing with us their database to assess the health workers that were scribing, if they were actually health workers, if their accreditation were valid. So even though we know people are health workers and registered in the council, we should know if they're going through any punishment or sanction before referring them. So the legal framework is the ordinance of March 31. And now we can see the distribution of the health workers that were registered in the system and the amount of health workers that actually concluded the training. Some of these workers have also carry out the training that is on the virtual website of PAHO. Dr. Malicho spoke about this virtual space yesterday, and we went through a very cool training. There was a realistic simulation training for clinical management for patients of COVID-19. So it talked about hospitalization for these people, and these health workers that undergo this training, they're not included in this 345,000 workers. So the number is actually larger than that. So this is an update that we carry out on December 31st, 2021. So we have 1,121,000 employees subscribed. This will be updated, and we'll try to use this database the most.
And for SOS report, of course, that we're going to follow strictly the determinations of data production, the general law of data protection. We must be very careful with those data nowadays. So everything's going to be done very carefully, the most transparent way possible. One thing that called our attention in Brazil Conta Comigo program is that here we have a distribution by the professional categories, and this column highlighted in yellow presents a relation between the number of professions that the council prepared, that the database that the council graduated the number of professionals, and the percentage of these that signed up in the strategic action. So I can see that we could highlight the physiotherapy and occupational physiotherapy professionals, and nutritionists as well, 66%. And here we also, phoneaudiology, 54%. The physiotherapy was 86%. So we have a high number of professionals. So of course that we have to understand that these percentages of professionals registered make clear to us that we do not have a relation. Well, this database does not reflect the cut or the percentage of each professional category in Brazil. It doesn't reflect exactly. It's not a reduced image of it. So all of the data and the way that we deal with this database, we must have this special look to comprehend and understand what quantity of professionals we are treating with and how to deal with it. Brazil Conta Comigo made us notice that the more the professionals, well, here we have the number of professionals that were willing to act, to work in tackling the pandemics, but the more that they were willing to do it, they're not necessarily, as I said yesterday, not necessarily they were willing to leave their state or municipality for this work, and for obvious reasons. Maybe for having another job, or maybe because they didn't want to abandon the family, or maybe because they have people from the family that need some special care and this person cannot be away. So this and this update, this made us adjust that to see how the health professionals is willing to do it. We should have this information on where do they want to go. They want to work in their own municipality, within their state, in their region, or any place of the country. Eventually, we are going to put also the support to international humanitarian aid. I believe that's it. I believe that's a good backdrop. I gave a little bit of the strategic actions and a backdrop for the following presentations as well. I'm here available in case you might have. Oh, I'm sorry, I was missing just one last slide, which would be 9 states and 11 municipalities requested the database. Well, state secretariats and municipal secretariats, we provided the database, and we also trained the professionals for the actions. So the database was requested, and they told us what was the needs they have, and the number of professionals that they had available, and the absent professionals, the volume of users that were demanding this network, and we would dimension to understand what would be the amount of professionals needed to be hired. This state and municipal secretariat made official with the Ministry of Health the support, and especially Manaus and Amazonas, we made a more robust support. Ministry of Health hired health professionals to to work in this municipality and state. I believe that's it for now. Thank you so much once again. I'm here open, available for any question, and I wish everyone a great working day.
Marcelo, muito obrigado pelo seu.
Thank you so much, Marcelo, for your presentation. It was a wonderful presentation. It brought to us important elements related to a policy adopted by the Ministry of Health as a way to tackle the COVID-19 pandemics, bringing an axis of integration between professionals, residents in the health, and academics as well. So it's a huge task force being developed by the Ministry of Health to try to optimize and make available more human resources in the field of health, to strengthen the municipalities, the states, as a way to work better on the pandemic's control. He also presented to us an important aspect, which is in relation to this database, which is concentrated in the Ministry of Health, and also focus specifically on how to lead and organize the announcement of this database in an ethic way through the Ministry of Health. So we can have an idea of this dimensioning of human resource that was made available for the states and municipalities, or offered by the strategy Brasil Conta Comigo. Thank you so much, Marcelo, for your presentation. And now I invite Professor Maria Elena Marziali. Professor Maria Elena graduated in nursing by the School of Nursing in Ribeirão Preto from the University of São Paulo. She's an expert in hospital administration and occupational nursing, labor nursing, master in sciences or psychobiology, and doctor in sciences and nursing. She's a professor of the school, and she's also a professor of the school in the general specialized department since 2007. She's director of the Nursing School of Ribeirão Preto from the University of São Paulo in the term of 2018 to 2022. Researcher for the National Council of Scientific Development and Technological Development, CNPq. Professor is the leader of the Center of Studies in Health and Labor, and she controls the network of prevention of accidents, labor accidents, and the network of nursing and occupational health headings. This network involves 8 countries. Professor is also the member of this occupational health for the Autonomous University of Mexico and the International Network of Nursing in Mental Health. She gives consultancy and advisory to several institutions, agencies, education institutions in Brazil and abroad. Coordinates the project AGIR of 2020, evaluation and management of the risks and contaminations of the health professionals in the COVID-19 context. Professor Maria Elena Marziali, the word is yours. Thank you so much, Professor Pedro. And I'd like to greet everyone here with us, watching us and listening to us on YouTube channel. And today, our activity would be to show what we have been doing during this year with our group, bringing these indicators and these results from this research by the two PAHO, Brazil, and Ministry of Health subjects in a way to give some feedback on how the health professionals and residents and students connected to this strategic action, Brasil Conta Comigo, Brazil Count With Me, have faced or have been facing and tackling pandemics, COVID-19 pandemics in Brazil. Today I will bring some results of the northern region, and this study is continuing. We already collected the data for the southeast region, which is being analyzed by our statistic analyst, And we are also collecting data in the South region, Midwest region, and soon we are going to have an overview of Brazil as a whole. So I will just excuse myself to start this presentation. Can you see my screen? Yes? Yes, we can see it. Okay, thanks. So this project has several authors, myself, Mariana Maziara, Alexis Jones, Flores Cassanotti, Fernanda Ludmila Rossi Rocha, Maria Lúcia do Carmo Cruz Covazzi, Pedro Falha, Jaqueline Almeida Balesteiro, Vivian Meninel, Fábio de Souza Terra, Isabela Fracaroli, Graciele Aires Garcia, Heloísa Cardoso dos Santos. So it's proposed by the School of Nursing in partnership with the School of Medicine in the University of São Paulo and the Federal University of São Carlos through the Department of Nursing as well, and the Federal University of Alfenas through the Department of Nursing as well, and we also come with the support. And well, a very important support, not only financial, but partnerships, support in our meetings, and every Friday we met for over a year with all technicians from Brazil and Ministry of Health. Okay. So yesterday it was already mentioned by Dr. Mary Cho that I have to contextualize how this project appears. It comes with the idea to tackle what we could or focus on the help that we could give to tackle the pandemic with scientific research. So the pandemic represents a multidimensional health emergency, as we could see, sanitary emergency that modifies people's lives in this century, and it's a global crisis bringing difficulties and challenges for the health services, but it also brings problems, highlights pre-existing problems, and we already have the uncertainties related to facing the diseases, the treatment, diagnosis, and also how to deal with it. It put into evidence the difficulties faced by the health professionals, especially in this greater vulnerability scenarios, economically and socially. And it brings, especially in the beginning of the pandemics, a global shortage of PPEs and ventilators, as mentioned yesterday wonderfully by Professor Zufu. Well, the risks, with this context, the risks of contamination for the health professionals were identified due to the severity of the disease, but also due to the improper conditions of work in some places at a world level, low level of workers available in some regions. Here in Brazil, we have this overview, which is really clear to us of lack of health professionals, mainly in the north and northeast, and even more than that, the professionals trained for the giving service to complex patients such as SARS patients. And with that, the existing professionals would be overcharged, as an overburden. Literature has shown us that, and they start suffering physically and mentally. And with that, we have an impact in their participation, in their presence. So they work without having conditions of it. So we have a shortage and a lack in the productivity and the absenteeism, which leads also to lots of them professionals quitting the profession. So this brings an impact on the health of the professionals, but also on the assistance being delivered to the population. And that is a very complicated issue. But in relation to this, in fact, I wanted to highlight three topics. First is the management at work for the professional, but also for the team. We could see that during the whole period, there is a deficit of professionals. And that changes a lot the organization of this work. People that have never worked in ICU before, they were trained quickly to take these positions. And we had here in Ribeirão an experience with Hospital das Clínicas that our school helped in the training of some of these professionals. So we had this difficulty to, in a short period of time, we had to train the professionals to take care of so complex patients. The exposure to risk increases after the moment that you need to review the flows, and the demand is highly increased, and this made that the indicator illnesses to be present in a very strong way. Not only the infections for SARS-CoV and the diagnosis of COVID-19, but also causing death to many health professionals. So that has a cost for the institutions, mainly for the government. 75% of the health assistance is through SUS, and then we have this financial expenditure.
Então, do nosso trabalho foi
The
avaliar
objective of our work was to assess the risk of infections of health professionals, residents and students in Conta Comigo, working with COVID-19 patients, and we have to analyze the prevalence of morbidity in this population. This first phase, then, that I will focus on this objective, and then Professor Alex will talk about the mortality rate. So we could collect this data. We selected an instrument in WHO, which was announced in March 2020, right in the beginning, as an instrument to face the pandemic, COVID-19,
identificação, né, dos riscos
to identify the risks that these health professionals were exposed to.
Sabia do controle de prevenção a riscos e também
controls, and also the management of this. So we translated and adapted culturally to the Brazilian context the instrument risk assessment and management of exposure of healthcare workers in the context of COVID-19. We also characterize the resident professionals and students contaminated by SARS-CoV-2 virus according to the social, demographic, and occupational characteristics, analyzing then the risk of contamination. And also the prevalence of morbidity via COVID in this population. In the north region of Brazil, following the social, demographic, and occupational and risk of exposure. So our study had two phases. The first phase, a methodological study, which was a translation and adaptation, and continued by
lógicas da organização
standards from WHO, and the experts, in the five phases, traditional phases of the study. In the second phase, then we had an exploratory study, which was a study with these people that were registered in the action Brasil Conta Comigo in the northern region. And this study was approved by the Ethics Committee of PAHO and also the Nursing School of Ribeirão Preto. The first phase, well, what we could see was the questionnaire has two parts. The first part characterizes the risk to that the workers, healthcare workers are exposed when working with COVID-19 patients, classifying those risks into high risk and low risk. And the second part is guidance that must be given to those people that have been contaminated or that are exposed to the contamination, so we could have a previous identification of the risk for the planning of management of the case, actions to manage those cases with the health managers. So the great difficulty for this instrument, for what we're proposed to do, is deliver the indicators that the Ministry of Health then could really use, and their strategies and their strategies to face these pandemics, but also to other health emergencies.
Quando a gente estava executando essa tradução, nós
And then when we
percebemos
carry out the translation, we noticed that
uma desatualização de
there was a
informações, porque
lack of
esse
update
projeto ele foi feito
towards the
em
information
março
because
de
this
2020,
instrument was prepared in March of
os
2020,
estudos
and a lot of the
correspondiam
studies
isso, e
took
evidências
place after
científicas
that, and
foram
some
demonstradas
scientific
com relação a
evidence
outros
were
fatores
demonstrated
também
regarding other factors
indicadores
that would
de
also be
exposição a risco.
indicators
Com isso,
for
nós fizemos uma
exposition risks.
ampla revisão da
So with that,
literatura,
we carry out an
uma
ample
sistemática
review,
da
a
literatura,
systemic
com
review of the literature
protocolo
with
de
protocols on Prosperous
a
system
partir dos dados ali
in which,
coletados, nós
stemming from the
revisávamos
collected data,
as
we carry
informações
out the
deste
update of the
questionário
information of,
como questionário
included in this questionnaire.
que seria então
And
colocado
this questionnaire
índice
would be
esse formulário
an
inicial
appendix, this
com
initial
informações
form with information, with social demographic information also on
a
professions.
versão em português do
So
questionário,
this is the version in
chamada
Portuguese of the questionnaire.
versão de
It's
exposição
called
de
Risk
profissionais de
Assessment
saúde
and
no contexto
Exposition
da
Managed for health
Covid-19.
workers
Então,
in the context of COVID-19. So it was
atualizada,
adapted,
para essa
updated, and
população de
validated
profissionais de
to
saúde
this population of health workers, residents,
né?
and
Cujo
students as well.
índice de validade
And
foi
its
de
validity
0,96.
index of the content
E o
was
questionário
0.95,
complementar, então, que foi
and there was a
anexado
complementary
à OMS,
questionnaire
teve um
annexed to
índice
this
de validade de
WHO questionnaire
0,97,
with a
indicando então a
validity index of
suitabilidade, né, desse
0.97,
questionário
which
para o uso.
indicates the
Esse
suitability of this questionnaire for
questionário,
usage.
ele é de livre
So this
acesso,
questionnaire
está
is of open
publicado no
access.
site
It was
USP-AGIR,
published
que é o site
on
do nosso
USP, the University of
projeto,
São Paulo
e também foi
website,
publicado
and it was
o
also
processo
published,
pela revista
the entire
latino-americana de
program, by
enfermagem.
the Revista
Bom,
Latino-Americana de Enfermagem.
nós temos então
So with that,
o que aonde o referencial
we
teórico,
have
né, que embasa
what
esse
was
questionário.
our
Ele
theoretical
traz a
basis for this
definição do
questionnaire.
risco de
So
contaminação ao
it
SARS
established
num
the
primeiro
risk
item,
of
a
contamination for
adesão aos
SARS.
procedimentos
The
de
first
prevenção
item
e
is
controle
addition to the prevention
durante as
procedures and control of
interações de
infection
prestação de
throughout the
cuidados
interactions when providing healthcare to
também uma
COVID-19
questão
patients.
que
What it says is
o profissional
the health worker
participante, né, do
or
nosso
the
estudo,
participant
ele
of our study,
respondia se
they
ele
should
sempre
answer
usava
if
luvas,
they
máscaras,
always
escudos
wear
dentais,
gloves, masks,
respeitando
aprons
o
when
protocolo do
providing
Covid,
support
e esse
to COVID
sempre
patients.
significava
And
mais
this
que
always
95%.
meant more than 95% of
E eu chamo a
cases.
atenção
So I would like to highlight at this moment to
se
this item.
havia
I would like to highlight this item
substituído o
because if
CRP
they had
por um
replaced their
protocolo
EPIs
preventivo,
as in a protocol,
dizendo que
for
quando a
instance,
máscara
saying that
envelhecida, se
the
havia
mask
o descarte deste equipamento de
whenever
proteção
the mask
individual.
was not
Eu
being used, if it should be
coloco
discarded. So
um
this is
destaque, por quê?
one thing that I would like to stress.
Porque
Why? Because we know
muitos
that
hospitais e
many
famílias
hospitals
a
in Brazil
reutilização de máscaras
reutilize
isso
masks.
é uma
So
realidade.
this is a huge issue and it's a reality in Brazil.
Esse alto risco se
And
relaciona com a
this risk
higienização das
is
mãos,
also related to hygienizing their hands
além
or
disso,
hand sanitation. And besides that, just a moment, she's looking for the slide.
além disso,
Okay,
o
and
segundo
besides
item é
that,
adesão
the
aos
second
protocolos
item is
de
addition to prevention
prevenção.
procedures
Na realização
and
dos
infection control
geradores de
during
aerossóis.
the procedures of aerosol generators. So they use this equipment the same way that the previous item did. And the third item is if they undergone accidents, work accidents with biological materials. In the questionnaire, in the entire questionnaire, if they answer positively for this questionnaire, they will be characterized as a self-risk, a self-contamination risk, which means they have a high risk of being contaminated. So any spills of biological materials, or airways secretions. And then we get to the second stage, which is the stage of the study in which we carry out the questionnaire for the targeted audience of the northern region of Brazil, so the population of health workers, residents, and students. Like Marcelo said before, I'm not going to say it again, but we had this target audience of 42,542 people linked to Brazil Conta Comigo, the scholars, the health workers, and the residents as well. So we got a response to this questionnaire of 1,055 people who answered the questionnaire. So this is our sample. Why did we choose the northern region of Brazil? We selected this region to start our study due to the struggles that they undergone throughout the pandemic, not only during the pandemic, but also the frailties or fragility that were already described, both in the people distribution, personnel distribution, but also in regards of the struggles they face in terms of territory, considering that a large share of the Amazon rainforest is within the northern region, and this makes it harder to give health support to this population. So with that, we have this data collection from May to August 2021, done remotely by implementing the questionnaire in Portuguese, which was standardized to be used as a tool through the Red Cap system, and the invitation was sent by the Ministry of Health. The analysis was carried out with descriptive statistics and logistic regression, binary logistic regression, considering the two outcomes, the high risk of contracting a SARS-CoV-2 infection and the self-referred infection. So this was the way that we planned this study. So the AGIR group carried out the validation of the instrument, CGTS provided the information from the database, Grupo AGIR prepared the Red Cap platform. It also tested and implemented the platform. CGTS has distributed invitations to the health workers, and now I'm calling them professionals, including the residents and the students. So they carry out the questionnaires. The group has collected and analyzed the data, and today we're going to show you the outcomes. So as there's results, we have as a social demographic feature that out of the 2,054 participants of the northern region, we got the most data from Amazonas and Pará, so respectively 46.4% and 25.6% respectively. So there was a majority of women from 25 to 39 years in these two states. As to the professional categories, we had psychologists, nurses, pharmaceuticals, physiotherapists, physicians, nurses, amongst others. And we had a smaller number of residents and students, but it's also proportional to the number of people involved and that could be doing this work. So we had that the nurses mounted, summed with the nurse assistants are equal to a total of almost 50% of our sample, followed by the pharmaceuticals, then the physiotherapists and physicians. As to the scholarity level, one thing that really stood out and that is very different from other populations of the health workers in other areas in their distribution at a national level, what makes them different is that most of them have a post-graduation and specialization degree. So it means that these workers, they have this differential, and we only have 5% are for technicians, 5% for high school, and 6% of students. So with that, we know that these people could give us an answer considering the knowledge they have on the infection disposition that would be seeing it moving forward. The lifestyle, 34% do exercises, 2.6 are smokers, and 5.9 drink alcohol 2 times a week. 21% had pre-existing illnesses. This is important. And why? Because we know that this infection has this variable as an issue to getting ill. So the contamination risk. So we're also looking at the external environment. And as a result, we got 72% of the participants lived with other adults between 19 and 59 years old. 68.2% stayed in their household, even if they were living with family members that contracted COVID. 36.1% use a collective transportation means like buses, and this was one of the contamination risks. And they went to social places like supermarkets, 77%, the banks, 29%, and commerce in general, 24%. And 55% of these people needed to be isolated as they were infected within their own households. In regard to the distribution of responses of our health workers, in regard to the organizational features, I would like to stress the working conditions that were provided for these professionals. So regarding the shift breaks, I would like to stress that 55% have never stopped to do a break. And this is a very severe issue considering their the work day, a health worker's work day, especially during the pandemic, because we knew there was no replacement for them. So this was very disruptive. This was very tiresome, both physically and mentally, and was significant. So spaces for resting. This is another issue. Either they didn't have it or it was improvised. So it goes up to 50%, and it stands out in terms of the conditions that are offered for these people. Regarding spaces for eating, this is a bit better, but all of the workers should have it, not only 70%. So the origin of food is something that also stood out when we carry out our service and identified the origin of this food, especially during the pandemic. So we noticed that they were bringing from home. So there was no offer from the health system to more than 50% of the people involved or the sample. And now I'm like to stress out the risk activities, which means the activities that are considered risky and that were carried out by this health worker. So 90.7% provided support to COVID patients, 55.8% carry out procedures for aerosol generators, and we know these are the most risky ones. 27.5% carry out CPR maneuvers, and 13.9% undergone work accidents with biological fluids. So regarding the EPIs and protection materials and the vaccination, 97.2% used EPI during their support to the patients with COVID-19. 92.1% of these professionals use EPI when undergoing the aerosol generator procedure. So it means some of them are not using it yet, and 67% replace the EPIs as per the protocol. What does that mean? This means that the protocol was not included in the questionnaire. So it's important for us in the next assessment to know what this protocol means. 80% of the people had cleaned their hands before and after contact with the patients. And it also stands out that 63.7% reused that N95 mask. As data were collected until 2021, at the time, 66.6% had been vaccinated with 2 doses. And out of those, most of them received CoronaVac. So there was this statistic that between working with emergencies and ICUs and high risk of infections, but also in terms of the infection of SARS-CoV-2 and working in ICUs. So there was also a statistic relevance between the bronchoscopy and a high risk of infection. So there was also a statistic element regarding the infection of SARS-CoV-2 in airways and cardiopulmonary CPR. So these are the procedures, let's say, that the health worker is most exposed to the risk. So here in table 3, we can see the answers of the health workers and students as well in regards to the assessment of the quality of EPIs they were using. So I would like to stress that if you look at this table, 60 to 70% consider it good or great. But we like to stress the fact that they didn't receive EPIs. It was not provided. So this is, it's a concern for us in regard to the need of these materials. Once these EPIs are recommended by PAHO, but also by Anvisa and the health ministry. So this was something that we struggled with to provide some EPIs. 63.7% of the participants have informed that they were reusing the N95 masks or equivalent respirators. In Brazil, different from other countries, we have this practice, unfortunately, but the outcomes of this practice are still being investigated scientifically. So if this practices is indicating more risks, and some studies show that yes, it does pose more risk, but we do need to carry out the studies in Brazil because this practice has been used mostly in countries with social economic debits, let's say. So to this end, what poses a risk to us, which is also related to reusing the mask, so how this mask conditioning is performed. So since we don't have this technical procedure here in Brazil and this rule, each of the professionals is doing their own way, in a different way. And what we notice is that this mask conditioning is a risk factor due to the indicators that we found out. So they use plastic packages. We have not been perforated, but we know that the masks should be ventilated. And this is a wrong practice. So this is another issue that we need to think about and tackle and study. So most of the health workers have used EPIs. They clean their hands and the surface of their skin, the surfaces as recommended. And so we got the statistics between usage of all EPIs and a high risk of infection, with the exception of surgical masks for procedures. However, there was no significant statistics as to SARS-CoV infection. So there was the risk, but not the infection. So most of the professionals have used EPIs, have cleaned their hands as per the recommendations. And then there was a statistic prevalence between the use of every type of EPIs and the self-risk of contamination. So there was also a statistic significance as to protective glasses as well. Regarding the types of work accidents, all of them were significant in regarding the self-risk of contamination. However, they were not significant regarding the infection by COVID. And here we can see with oils and the skin and these skin accents that were already noticeable before the pandemic.
There was a statistical significance in the individual level, households with people with COVID.
Aqui a tabela, ela mostra
This
o
tells
modelo
us the model
logístico
of logistic
nacionais
action, including the organization,
e ocupação
individual and occupation
única.
features. And this was the only variable that had statistic significance. And we can look to the capacity building and instrumentalization, which is at the beginning of the pandemics. We have an indicator in literature that this would be a practice which
sendo responsável por
was
muitas
being responsible
infecções,
for lots of infections.
treinamento
And we had the training so the people could then use their equipment properly. Okay, I'm to conclude. Among the organizational factors associated to high risk, we can highlight those of lower frequency of outcomes, such as the quality of the surgical masks in all categories studied. That showed significant adequation of the shield,
e a capacitação dessas
the capacity building of those people as well. Here, just to highlight, when we see the high risk and the infection, we see that the healthcare professionals and students, 41.9% of those identified high risk, but the infection was even higher. It was in 50.2%. It means that we have the need of a training, a greater training for the recognition of what is risk factors and what isn't. Here's the prevalence of the risk infection. High risk for the infection, mainly in relation to the Amazon state and Pará, where this risk happen in greater percentages. And this is also the point related to the outcomes of the days that they had to be away from work, corresponding to 700 days lost at work. And I will go straight to the conclusion that the exposure management must be done by the provision of tests and also the self-monitoring of the professionals and the adoption of the prevention strategies and the standard precautions and the droplets as well, and the proper use of PPEs and continuously hygiene, sanitizing and cleaning your hands. But I want to highlight that the institution must have a support network, a psychosocial support network for those workers, mainly in the quarantine aspect, when the illness or disease is confirmed, and the review of the protocols and flows, and the performance and the organization of more specific trainings, mainly in relation to the development of more complex activities. Our group presents this guide of information for the health managers, considering how to assess and how to manage those risks. And this guide or manual will be distributed by the Ministry of Health, and it currently is available in our website for our project. And here we also have some informative bulletins or from this year, and we consider the need to take the information to the health service managers while tackling COVID-19. And here, on behalf of our whole team, I'd like to thank you all for your participation, for your collaboration, and I hope that our work can help. And here I'd like to highlight the presence of the technicians from the MOH, mainly Marcelo and Artur. Maria Alice in the beginning, and she's from PAHO, a technician from PAHO in the beginning of the project, and Kriyashin Goshi currently. Thank you so much for your attention.
Maria Helena, pela excelente.
Thank you so much, Professor Maria Elena, for the wonderful presentation, a clear presentation to bring all the results of the studies developed by the group under coordination. And you brought very important reflections to us around as this dimensional sanitary health emergency. That's an important
Sobre a vida das pessoas.
About people's life and the healthcare professionals, and brought to us very important in relation to creation of two studies that were done, methodological studies, which have contributed for the organization, and more specifically about the possibility to this instrument to become self-applicable online, so the researchers and managers could use it during other studies. And also the results of the transversal study. These results are important in relation to the occupational and organizational risks, which have been demonstrated during her presentation. And this then would be a very important tool for the management on how to tackle and face the current pandemics and possibly in future pandemics as well. We're going to be free from that. And also the main products that have been a result of this part of the study that is being done or is still on. So this study, remembering that it would be data from the north region of the country, of Brazil, which demonstrates above all how this pandemic interfered over the morbidity and the mortality of the healthcare professionals, mainly intervening in the health and the work process of these workers, our professionals, and also having very significant interference in their work process with this possibility of sick leaves and comorbidities or mortalities. It interferes also directly in the organization of the institutions. So they are fundamental points which were up to now translated into the guide of irritations and the bulletins that were published and available, showing us how this pandemics had a huge interference over healthcare professionals that were part of the sample of over 1,055 people, related mainly to the nursing, pharmacy, therapy, and medicine. Okay. So thank you so much for your presentation, and I'd like now to invite for the presentation Professor Alec Jones Flores Cassianotti. Professor Alex is an epidemiologist and postgraduated and mastered by the program of Practicalization in Infectious Diseases of the Faculty of Medicine for the University of São Paulo. She coordinated the database for the Brazil cohort HIV/AIDS 2004-2011, and he coordinated the regionals of São Paulo during 2011-2018, and coordinates now the modeling group for the ProviMed study 2030, developed with a partnership between the Faculty of Medicine and the University of São Paulo, PAHO, and MOH. The professor has experience in epidemiology, biostatistics, working in the following topics: epidemiological outlining, epidemiology, data analysis, populational studies, medical demography, epidemiology of HIV/AIDS, physiologics, and logics for consistency, and this, the system especially applied to medical decisions. Professor Alex, please, the word is yours. Thank you for the kind words, Professor Pedro. Initially, I'd like to thank for the opportunity to be here in this important event, show a little bit of our experience with the data mining and data analysis, and show you a little bit more of information after the wonderful presentation made by Professor Maria Elena, and the wonderful presentation also made by Marcelo. So I'm very glad to be able to show the group this presentation, which will focus on the illness and mortality through secondary databases. I will make now, I will share the screen now, my screen, and I will ask if you can see my screen being shared for now. Yes, could you just put it on full screen mode? Is it already on presentation mode? No, not yet. So let me do that here first, like this, and now I will share the screen. Okay. Perfect now. This would be the other presentation that I was looking at yesterday. I'm sorry. Let me just open the correct presentation here. Just one more minute. Professor Pedro, here. Okay, I had a difficulty here, but I believe now it's okay. I could solve it, and now I will be sharing the presentation. I work with the versioning of documents, so I mixed up some of the documents. So now you can see my screen. Thank you very much, Professor Pedro. And now I will continue the presentation, and remembering that this is a subtopic inside the project AGIR COVID 2020 that has as an objective as responsible the nursing school of Ribeirão Preto, coordinated by Professor Maria Elena, and it has the subtopic of the aspects of mortality of the healthcare professionals, residents, and students in the health area in North and Southeast region. Of course, that we're also exploring the other regions in Brazil, but this presentation has a focus only in these two regions, as we could have it as a comparison for the extremely heterogeneous regions in Brazil. Initially, I will be working with the sensibilization, showing you that, that this topic has been extensively announced by the scientific literature, bringing the impacts and those issues about the illnesses and the mortality of the healthcare professionals. We already have more than dozens of articles, including important reviews about the topic. And we already have an experience on how important would be and what they represent to the health services, the health professionals represent the health services. And so this I bring from another study that I am also a co-author, so you can understand that most of the investments for tackling the COVID-19 pandemic were basically dedicated, focused professional groups that were in the front of non-medical workers in all modalities of services, in emergency, in ICU. And the greatest investment was in human resource, in health. And this matter of the illnesses of the healthcare professionals has an impact basically on the turnover of the teams and on the overload of the teams that have less professionals, and automatically this overload increases the tension, the stress on those teams, and at the same time it makes the teams even more susceptible. What increases also the labor cost for health services, closing this cycle that brings a lot of impacts for the management of emergency situation like in COVID-19. So you could have an idea also at a awareness level. I bring another information about the presenteeism and absenteeism. This is a study which is in the literature already available, and it estimates that there was, in a specific reality, 32,209 days lost with absenteeism COVID-19, with
de 1,3 milhões
1.3
no serviço de saúde deste
services at this place, at this location. And these slides and these initial slides then demonstrated the importance of studying those topics, and we now go into those most methodological on how we out these traceability or the tracking, and it's different from what Professor Maria Elena presented before. You know that here we go basically into secondary data, and here we have ministry ordinances that fostered this availability of secondary data. We had a database dedicated to the notification of the healthcare professionals, which were registered by the CBO registry, which indicated the category, the profession that individual occupied when the notification was made by the health service. And we made a tough work of compiling a total of 78 databases, much more than one database for each state. And we had, at the end of this compilation, a total of 1,202,829 cases of health care professionals that were notified with COVID-19. We can remember that in Brazil, until 2021, we're talking about around 5,300,000 health professionals to 5.5 million healthcare professionals. I will now talk about this matter of the illnesses in these following slides. And out of these 1,912,829 cases were considered for the beginning of the analysis. There are healthcare professionals that take other positions also, and they are notified administrative positions, public administrative positions that are not working directly in the health service. So in that number presented, initially we made we cleaned and we trained this number, and then we start listing some criteria. Cases where the exams were conclusive or the field of exam had no information. So we applied the cleaning, and we excluded 288,000 cases. We stayed with 1,645,366. We included individuals with more than 80 years of age. That's a demographic criteria in human resources and health. So we included this number for 4,800,000, and we stayed with 1,640,508 cases, and then we excluded 528,120 CBOs not selected. Codes of profession that did not represent for us in that moment an understanding of what would be the frontline professions. So we had, in the end of this flow chart, and divided by each of the professions, the total of illnesses of individuals that had illnesses and notified due to COVID-19. So we called the attention here, of course, that proportionalization is related to the total of cases, but the nursing technicians would represent basically half of this sample, 42.8% of this universe, representing almost half of it. And other important categories, the nurses with 21.3% and doctors with 15.1%. We must also remember that these are the professional categories of greatest weight in Brazil. We have between technicians and nursing assistants more than 1 million professional resident activities in Brazil, such as the class of nurses and doctors that together they probably add up around to 1 million.
So this number already represents the profession in a very relevant amount in terms of infection per COVID-19. This graph, what it shows us is how the notification process was carried out for these health workers, reminding you that our investigation calendar, it's focused on until July 2021. So we monitored the first wave of the pandemic and also the second wave of the pandemic from January 2021 with a lot less cases being notified within health workers. So now our focus here is exclusively on the northern region of Brazil. The data that we have in blue refer to the total amount of health workers that were notified, and the numbers in red, they represent to the total amount of COVID-19 cases that were confirmed by lab exams. So this is an important rule, is that it should test positive in the lab exams that we selected. So we had some states in which the positivity rate was higher than 50%, as in Amapá. And there were cases in the positivity rate, and this time period was inferior to 35%, as in Acre and in Rondônia and Tocantins. So this table here, it's quite interesting, and it shows from the perspective of the total amount of health workers. And at this time, I need to remind you that this amount of health workers in Brazil refers to the northern region. So my cutout is exclusively focused on the northern region. So this 42 million professionals are Brazilian that are located in the northern regions of Brazil. And we have a percentage of flu symptoms that were notified, and the nurses are most of the cases that were notified. So I'm going to show you on the screen because the numbers can be quite small on the screen. So flu symptoms, you can see the number that there was a large notification followed by the technician, the nursery technicians, then followed by doctors, that one of the most affected professionals on the front line, and the total amount of notifications of flu symptoms that for the northern region was at 35% at the time. When we look at the percentage of COVID, this percentage in comparison to the total of flu symptoms, we have among the technician and nursery assistants and between nurses and doctors, but also among the nutritionists and other professional categories. Most of all, among these technical jobs, which are significantly affected by this infection, which is COVID. So with this infection coefficient per category of workers, you see that our comparisons is not more about flu symptoms, but as to the number of professionals. So once more, we have the nurses as being the category in the northern region with the highest impact when we comparing that the southeast region of Brazil, the states with a higher amount were of COVID notifications. So in the first states that you can see on the screen, for that we're considering just São Paulo, Minas Gerais, and Janeiro. We're not considering Espírito Santo due to the lack of data. So almost 433,000 cases, amongst which 142,684 were detected cases of COVID detected by lab exams. So we have quite interesting data. São Paulo had a positivity rate of 30.4% amongst health workers, which is quite similar to Minas Gerais, as in Rio was almost twice the size, this percentage of this infection rate of COVID. When we're looking at the health workers categories, the outcomes are quite similar when you compare to what we saw in the northern region. However, there is a difference between the second place and the first place. The first place here is also the nurses with disinfection coefficient of 185, 147 per thousand nurses. So if you stop to think about it, almost 200 cases per 1,000 nurses acting. So this is something reasonable, followed by 116,000 for nurses, assistants, and technicians, and 88 for 1,000 for the physicians. So in the southeastern region, this impact of the illness, it was reduced when you compare it to the south, to the northern region of Brazil. In the southeast region of Brazil, we have 63.7% of cases. So I'm going back to one slide here. As you can see, the before, we have 132.7020 per 1,000 cases. So regarding the data on the sickness, we were not able to stress within the database the sickness rate for residents, specifically for residents as the health workers. However, of health workers that were acting, but within the medical residence programs, the survey has allowed us to verify that the positivity rate among these individuals, most of all among students, it was inferior or lesser than what we saw with the other health workers. And among residents, it was also a lot less than what we saw with other health workers. So I would like to remind you once again that this data came from the epidemiological survey, not the reference service or the secondary data. So on the mortality rate, which is a very innovative subject in this project, due to the strategy that we're using, we should stress some very important matters, such as we had this database in which cases of airway syndromes were notified. This database was also carried out through an ordinance of June 2020, and it's quite complex. And on the other hand, we have the database from Brasil Conta Comigo project that was quite strong in terms of having a lot of registration based on professional committees and councils for each of the professions that are involved within Brasil Conta Comigo. So this is quite different from the work carried out by the epidemiologic inspection. So we made use of what we had the best in terms of extraction and contabilization of data for both cases. And what we found out is that 30,216 cases were notified amongst health workers in Brazil. So you can see the workflow or the flow in Brazil, and then I'm going to move forward to the northern region and the southeast region as well. So out of this total of notified cases in Brazil, we had some cases that were not didn't lead to hospitalization, considered an exclusion criteria, then health workers that were no classified, either if they had COVID or not, we didn't consider them as well in the sample. We didn't consider professions over 80 years, professions that were not selected as well. So we got to 21,376 cases of health workers that had respiratory syndromes in the period that we analyzed. And once more, what we found was technicians and nursing assistants. They represent the larger volume of health workers. They represented 30% of these cases. But the physicians or doctors, they also represented a lot. They represented a little bit more, a little bit above 6,500 cases, as I'm showing right now. Obviously, physicians, nurses, and technicians, they represent the largest share of the database, indicating the rate of sickness, which is the classic form of COVID-19. So respiratory syndromes amongst professionals of the northern region of Brazil, what we found was 1,068 cases, of which 1,412 cases were classified as acute respiratory syndrome implicated in a COVID case, which means that was COVID with complications, with severe complications. So in Roraima, Amapá, Rondônia, with a high positivity rate, and we don't know how to reduce this percentage of the COVID detection rates was a bit lower. So once more, and now adding this new information that is quite interesting and it's important as well. What we can see here, notice, is that the northern region, we have 275 deaths due to COVID-19. So deaths due to COVID-19. So out of 1,683 hospitalizations, it led to a mortality rate. The mortality rate was about 11.33%, 11 per 1,000 health workers. So it's a reasonable amount. So differently from the previous indicator, amongst physicians, you have a high mortality rate due to acute respiratory syndromes due to COVID-19, followed by the technicians and auxiliary nurses and nurses as well, with a high mortality rate as well. But you can see here other health workers, and this data is quite important to report the technicians, lab technicians and radiology technicians as pharmaceuticals as well were included in this analysis. So what we can see here is that there were states with a higher mortality rate due to acute respiratory syndromes due to COVID-19. So Amazonas, for instance, with 24, almost 30, 25%, then Roraima with 33%, then Amapá with 29%, and others like Tocantins, Acre, in which this mortality rate at the time of the survey was a bit less, and the average mortality rate was 19.5% for the northern region. In the southeast region of Brazil, we had a total of 10,402 cases within health workers that presented severe acute respiratory syndromes, out of which we were able to define that 78.9% of these cases, which means almost 8,000 cases were COVID-19 cases. And it's important to remind you that we have other infectious agents involved in acute respiratory syndromes. So our idea here was to investigate in terms of COVID-19 because this was our focus. So here you can see in Minas Gerais and São Paulo, you can see that the percentage there of COVID-19 cases, it's inferior than the other states, and Rio de Janeiro and Espírito Santo is a little bit above 80%. So as for the southeast region of Brazil, we have the same table in terms of health workers distribution, and this stands out because epidemiology is a precise indicator if it's working or not, but what is different here is the intensity in which this phenomenon takes place. You can see that the southeast region of Brazil, 3.38 for every 1,000 health workers. So I'm going to go back a bit and show you that in the northern region, this coefficient, this mortality rate was 11.33%. So as you can see, the pandemic has affected the health workers differently from the perspective of a different context. So amongst doctors, you can see the mortality rate was quite high, followed by the nurses and technicians and nurse assistants. And I would like to stress here these two groups of lab technicians and radiology technicians that were not much put into the light as professionals that were affected. But of course, that when we're talking about lab technicians, we're talking about 4 cases for every 1,000. So deaths per acute respiratory syndrome. But it's important to remind that these health workers didn't get to 12,000 in the southeastern region. So this indicator is quite relevant. So when we look at some states, we got this impression. And when you look at the amounts here in Rio de Janeiro, the death rate was higher for the health workers. So at 14.15%, followed by Espírito Santo, as in Minas Gerais, 10.39%, and São Paulo with 7.56% for mortality rate. So it was the one with the least amount of deaths. So this relationship or ratio of what we monitor so far, of course, there are a lot of other data on profiles of these health workers that were not shared yet, and we're going to share with scientific community via the publications, journals, etc. But the method, the calculation, it shows the doctors and all the participants that are here today, the difference between the context in which the pandemic has affected health workers, the mortality rate in the northern region of Brazil getting to 11.30 every 10,000 professionals, as in the southeastern region, you get to 3.38 for every 10,000%. So you can see it's a ratio of 3.35 larger in the northern region than the southeast region. So some final considerations here for the audience. So I'm going to remind you guys that we're dealing with secondary data. Secondary data, they have their benefits and their weaknesses. Among the benefits that I would like to stress here, the cases notification was standardized by law, so that if the health work system struggles with notifying the cases, as we had with other acute respiratory syndrome illnesses, this led the health work systems to notify the cases within the specific systems. Obviously, it still has some biases in terms of delaying the notifications, most of all, the lack of notifications on these cases, like as the mortality rate, which led us to create a process for preparation this work in a different way so that we can understand the mortality rate better. And on the next slide, I'm going to show you the difference between the classic methodology, apply the fiscalization, the method that we adopted for this work. So we also consider that throughout this project, the new LGP got involved, and that made it a bit harder for us, along with other relevant bodies that are quite serious in terms of dealing with data, which is the Brazilian Ministry of Health, but also the ethical reports coming from our nursery school from Ribeirão Preto, and the nursery school ethics committee, but also the ethics committee from the PAHO, and with a lot of tact, are dealing quite sensibly with the managers in terms of protecting them, and we were able to get to a point in which we're able to deal with them respecting the LGPD, respecting the database, and also producing a product of extreme need for the national content.
And the integralization of these systems will come as a milestone for us that use secondary data for creation of public policies. Remembering that our databases will need to have single keys in the future, so we can work with aggregation, disaggregation, and create policies based in evidences or evidence-based policies. So you could have an idea. These major databases are really, really large. The notification database of illnesses is the same database where we have the notification of all individuals who were positive and were not in hospitals. So they notified. So we had to mine the healthcare professionals in millions and millions and millions of lines where all the Brazilians were. And this brings us a very reasonable consideration, important consideration about the availability of computational resources for this objective. And for last, the importance of these regulatory ordinances of notifications. Without these ordinances, we would be, let's say, we would be just in the health workflow, and in that different moments of the pandemic, they were extremely to the overburden of work, and we had lots of challenges in relation to launching this data into the system, and all the services counted with their professionals to be able to insert or populate this data for the health services. And so we could be tracking and tracing as we did this in the project. And just so you can you could see the clear difference of the work process, epidemiological current. When we bulletin to November 21, we saw a total of severe respiratory syndromes that did not exceed 1,000 cases. But when we look to this new workflow created by AGIR COVID project in collaboration with MOH and SAGET from the Ministry of Health, you could see the size, the dimension of the difference that we basically have. Well, here we can get to a collection of almost 15,000 individuals, and in the normal flow of epidemiological surveillance, we didn't reach 1,000 individuals where this notification was made. Okay, Professor Alex, could you just conclude, please? Yes, sure, Professor Pedro. I just want to show you all now then that we do have a website where we are hosted. Professor Maria Elena already was kind to bring the team, and I would like also to mention the team. I am the joint coordinator of this brilliant project developed under the wonderful coordination of Professor Maria Elena, Paolucci Marziali, a person that added to this brilliant work group I had the pleasure to meet, and only remote I believe of this group presentially, personally. So that's the work profile that we have now. And I would like to thank so much for the MOH technicians that were also kind to us, PAHO's teams, and also the researchers that really make a difference in this work group. And I'd like to conclude, Professor Pedro, bringing here 3 sentences from Michelangelo. And this seminar brought
dessas implicações, né? O maior perigo para a maioria
for most of us is not that it should be very high and we can't reach it, is that it is too low and we could really reach it. So we launched objectives in this project that in the moment really we didn't know that if we reach it, but they would be very powerful objectives. The workflow today, these 2 new workflows that were created by the AGIR group, and is brought to me to another Michelangelo sentence which says, I saw the angel and the marble and I sculpted until I freed it. It's a bit of what this work group remembers me in IG. And to close, that Michelangelo, when he was at 87 years of age, said, I'm still learning. As an epidemiologist, the epidemic show different issues to me as a professor, and I believe that Group AGIR brings this data and wonderfully with this, especially we're still a lot of stuff, especially these brief that we have. Thank you so much, Mr. Pedro. I might afterwards for questions. Thank you so much, Professor Alex. And you brought to us a wonderful explanation about the mortality of professionals and residents in the North region and also in the Southeast region. In this comparative study performed through databases presented here by Professor Alex. So he showed to us a very important difference among the 2 regions, between the 2 regions we have in relation to the illnesses and the severe respiratory acute syndrome. In this comparison, we can notice that really the northern region, as we all know, has the worst indicators in relation to the illnesses and also the mortality. And also, we can notice that the most affected professionals by the syndrome and COVID-19, most of them are present in the technicians category and nursing assistants, nurses, and doctors, followed by other categories such as lab technicians. So these data that were offered to us by Professor Alex give to us important indicators, so we can think about future actions to face future pandemics, or also to work in the current perspective, because we have not finished the current pandemic. We're still in this process, pandemic process. So thank you so much, Professor Alex, for your brilliant presentation. And I would now like to invite for the presentation Professor Emil Iftikhar. Professor Emil has been graduated in Literature of Physics by the University of Regensburg and has a Master in Physics from the Friedrich Alexander University in Germany. Professor is a researcher for the Max Planck Institute of Dynamics and Higher Organization in Germany. And during the COVID-19 pandemic, the professor has been involved in the modeling of infectious diseases, concentrating in topics such as non-pharmacological interventions during the implementation of the vaccination and the impact of the voluntary behavior of health profession in the dissemination of diseases. So to inform and to inform about this policy and also for the public, the professor has published lots of declarations with experts all around Europe, and he
vinculada aí com outros especialistas
to other experts
sobre o futuro
the
da
Delphi about the future of
importantes
in Europe.
estudos realizados
So
pelo
important studies carried out by Professor
Nós somos uma grande
were
honra de
very honored
fazer assim,
by to make his presentation.
de antemão agradecer a sua
I also
disponibilidade de estar junto
thank you so much
conosco
for your
nesse
availability to be here with
internacional.
our international seminar. Thank you. The word is yours.
A partir desse momento.
Thank
Muito obrigado.
Thank you very much. Just would like to correct that I'm not a professor yet, so but thank you anyways. I would now share my screen. Hopefully my audio quality today is sufficient. Can you see my screen? The presentation?
Sim, okay.
Great, thank you very much. Yeah, so thanks again for the kind introduction. Yes, I will now be talking about a prediction or a forecast on how the COVID-19 pandemic will develop. I will try to keep my show short, given the time that we have. And mainly I will be talking about the methods and results from a Europe-wide expert consultation that we conducted last year. So during this talk, I will first go to the motivation, then give details about the methodology, and then give perspectives for the coming months, and then for the coming years, and then conclude. So what we wanted to have last year was an expert forecast to better prepare for the rest of the pandemic and what is to come there. So because as of last year, there were various waves within Europe with different shapes of epidemics, even between neighboring countries. So we did really see differences in strategies, differences in mentalities that impacted how the pandemic unfolded in these countries. So the goal was then to exchange experiences, ideas, and solutions to problems between countries and between disciplines as well, because often in public discourse, only the epidemiological or the virological perspective was heard. So what we then wanted to have was to create a network for future pan-European discussions and cooperations and to build, to build a long-lasting, sustainable relationship. The problem then that of course occurred is that you have to coordinate all these different perspectives from a wide range of European countries with language barriers and also barriers between disciplines because they have different ways to understand and conceptualize things. So the method that we used was the Delphi method for group discussions and forecasts to then generate our insights that we published last year. The Delphi method is a method to reduce common biases in group discussions where there are facilitators and consulted experts. And the facilitators moderate the discussions such that the experts can exchange their insights and their ideas and arguments without falling into common biases. In this case, we recruited 30 scientists from 17 European countries, which are highlighted here in yellow on the map, with fields of expertise ranging from epidemiology to sociology. In the process, there are several stages of facilitators receiving and evaluating written input from the experts. And these results after each stage are presented back to the experts in an anonymized way. And in this fashion, the experts only consider the written input that they see and the synthesized text. So they only engage with the arguments and the citations and references that are there, and therefore specific mechanisms such as people being less willing to speak against people who are more senior or who have a high impact career behind them. Such mechanisms such as these are prevented through this process. We also did not allow for direct communication between the experts, such that all argumentation is based on the process and is clearly visible throughout. So in detail, we started this process with a set of questions that the facilitators prepared, where we prepared 4 different sets relating to general research directions. So one set of questions on epidemiology, one on public health, one on social sciences, and one on virology. And each set of questions was structured along the different headings. So we had questions regarding summer 2021 in Europe, winter 2021, then the next years, some questions regarding general related topics to these research directions, and then also on mitigation of viral spread. With these questions, we invited the experts and it also explained the procedure beforehand. And then these experts had to answer these questions and send these answers to us. And we synthesized the text from all these inputs. So we prepared a manuscript where we try to outline where are the convergences between argumentation and opinions, and where do the opinions diverge, and to really show where uncertainties also lie in the different forecasts. Then after we synthesized the text, we sent it back to the experts along with the individual inputs, which were anonymized. And then there were 2 rounds of revisions where the experts sent comments, suggestions, and corrections to the text, and we incorporated this new input to the text. After 2 revision processes, the text was almost complete, almost finalized, so the experts were only allowed to send minor suggestions to a text that was shared online. So at this point, the process was not anonymous anymore, and we then just accepted or declined the suggestions and then handed in the manuscript to a journal. So what came out of the study? For now, I want to talk about the coming months and first outline key factors that determine how it would develop in the coming months. And one thing that we have to see first is that the additional burden to healthcare system due to increased transmission of other seasonal viruses is relevant. So as this forecast has already been for the last months as well, we already saw a confirmation of these worries, because in many European countries, for example, RSV was of concern, especially for pediatric capacities before then the Omicron wave hit. Other key factors are whether there's a new variant of concern, whether vaccination coverage is sufficient, and what the responsive to public measures are. And if everything goes well, so there's no variant of concern, if vaccination coverage is sufficient and public responses are positive, then almost no new measures would be necessary. We would have lower fatality rate due to COVID-19, but the problem that would still remain is long COVID-19, where even more and more evidence is accumulating on potential problems. On the other hand, if it doesn't go so well, and now in hindsight, we can say that with Omicron, another worry appeared, re-implementation of measures is potentially necessary. And it's also quite likely that the reaction would be late, the experts assumed, because, for example, measures to responses are negative. So governments are very hesitant to impose new measures. So what are the measures that need to be implemented if case numbers rise again? One thing that I just said is to act fast, but it's also important to act fast together, especially if you are well connected due to fluxes of people between borders, which is especially the case in Europe. Here, the measures that you then have to take are the ones that we have that became apparent during these past 2 years, and are especially context sensitive. So, of course, every country has their own best measures to implement. But in general, it's always good to limit the number of people at public events. Encourage physical distancing and also reduction of indoor contacts, and preferably we meet outside. It's important to have good masks, especially in indoor settings, and also to require proof of vaccination, especially when people must gather in large numbers. And what we must not forget here is to really think about the individual support that we have to provide. So financial, social, and psychological support for all these, for people, so that they can adhere to the measures that are required to keep this pandemic at control. Here, the ECDC in Europe or WHO Europe could provide mutual points of coordination, for example, by giving guidelines and by collectively procuring material and other devices. So here in Brazil, the role could also be taken over by WHO or by PAHO. And in the end, the goal is to reduce infections, to first protect healthcare systems, because even with good protection against the viruses, a large number may still overwhelm hospitals and may also overwhelm critical infrastructure, especially if you look at quarantine. It's also important to protect children, that is at schools, to have enough measures at play so that they can safely take their education, and also to look at pediatric care capacities, because these are often not monitored as well as adult care capacity. And we also have less pediatric care capacity. So it's really important to keep an eye out here. And then also, if vaccination programs are still ongoing, it's to buy time such that, the country is better prepared with more vaccination coverage. Other measures that are relevant for novel variants and also to deal with the rest of the pandemic and beyond is to address misinformation, disinformation, because during this pandemic we have seen a lot of media coverage on the pandemic, with many people also consuming a lot of media, especially when they have to be at home. We have seen also misuse of media channels. So it's not always only misinformation in terms of false information that is being shared, but also voluntarily disinforming people and confusing them about the effectiveness of measures or the dangers given by the virus. So I don't think I have to tell here in Brazil what can go wrong if this is not taken seriously. So here it's really important to, for example, look at guidelines given by the WHO on infodemic management to sustainably deal with this problem of the infodemic. Another thing to keep up and to enhance is improving surveillance. So, for example, here you could look to wastewater surveillance, which is a very cost-effective method to look and sequence strains of new variants or maybe even other pathogens to early on detect outbreaks in a large community, and to then accordingly react to it very quickly before it can spread even further. Another way to improve surveillance is to increasingly look at people who are reinfected to see what strains affect them, so that again you can detect outbreaks very early. And then lastly, I want to share that it's important to continue the development of vaccines and drugs, as especially treatment against the COVID-19 disease will be increasingly more important to deal with this disease. So now let's go over to the longer term perspective in terms of the next years. So it's probably not a secret that eradication will likely not happen. This is also what the experts of the study assumed. And so the question is really, will COVID-19 stay a health threat for public health? So there are many arguments for and against. Some arguments for it staying a health threat is that it's more infectious and lethal than other coronaviruses, and that we also have this problem of long COVID-19. And on the other hand, the mechanism could work similar to other coronaviruses, where children acquire the virus early on without much harm, and then over the years build up more immunity, so it doesn't stay a health threat when they're adults. And also we might see even more progress in treatment and medication, which would further alleviate the burden. But in any case, it will stay important to keep up epidemiological surveillance, such as maybe is done with influenza. And then another topic that I wanted to go into is the impact on chronic diseases. This pandemic had a direct impact on healthcare services and regular care. So we had reduced access to primary care, cancellation of elective medical and surgical procedures, and also a disruption to screening programs. And this also, of course, is added to by what we just heard in the presentation before, that healthcare workers themselves were not able to work and provide these services. So what we are seeing is a progression of chronic diseases and complications of acute diseases, which the experts suggested might lead to serious disease within a 2 to 4 year period. So this would in the end lead to further health and economic burdens, being increased sick days, decreased workforce, lost productivity, and also increased healthcare costs. Adding on to this, we also have enormous consequences for mental health, especially healthcare workers, with all the stress that they had to deal with during this pandemic. And we also had a massive shift into home office for many branches of the economy, while supporting mechanisms for sound occupational health during home office are still not very well developed. So also here we might see health system impacts arising from this shift to home office. What we also see is in some countries increasing investment into pandemic preparedness, which might risk cuts in other public health sectors in terms of financial measures. And this might aggravate then the effects on prevention and control of chronic diseases. So what is really important then is to keep up financial resources or even enhance them to deal with all these health system impacts that we will see in the coming time. And also to, when we implement measures, to see that they're really co-created with other health professionals and public health specialists, such that they fit perfectly and are well thought through. So what I would like to do now is conclude with a general perspective on society, as this was also mentioned in the study. As we have seen a large increase of inequalities during the pandemic, or at least it has shown the inequalities that are already there. We've also seen erosion of trust into public institutions, and this really poses a threat to social cohesion. It's also aggravated by this fact of the infodemic and increasing misinformation and disinformation going around, leading to even more polarization. So here again, it's important to keep up infodemic management. And also, and here I would like to end with a quote from our paper as a way forward, is in line with the Sustainable Development Goals. Healthy lives should be a global common good, and initiatives like COVID-19 vaccines global access should receive more support. And support of low and middle income countries by high income countries is not only crucial to mitigate variants of concern, but is mandated by the principle of solidarity. In the long term, a global One Health approach to pandemic preparedness and control is crucial, respecting the interdependence of humans, animals, and the environment. And yes, with that, I would like to close my talk, and I'm now happy for questions.
Obrigado, professor Emil, pela sua
Thank you, Professor Emil, for your excellent presentation. We'll have some minutes for questions now, but I would like to stress here in your presentation is the importance of this cooperation network and solidarity network that was created between scientists of 17 European countries. This is quite interesting, the way that you organize it to deal with the pandemic, involving the epidemiologists, health workers, social workers, virologists, as a structure for developing this research that you developed for dealing with the pandemic. So what you post to us is an overview which is quite interesting, stemming from the European perspective in regards to the way they deal with COVID. So in Brazil, we have other perspectives as well, but as Europe was the continent that spearheaded this entire process, and it was aggravated quite quickly there, these perspectives that you showed us from this cooperation network, and to think about what kind of measures should be implemented so that we can tackle effectively this pandemic, the current pandemic, and the perspective of new strands as well. So this is quite important. So these measures and the reinforcement of existing measures that are not pharmacological, they are intensively developed by perspectives that are contrary to scientific evidences. So it's really interesting, everything that you brought to us as a way of reinforcing the things that we're trying to develop and that we're struggling with. So these guidelines that and the follow-up of the guidelines from the World Health Organization is quite important. So we should stress that. We should focus on these issues that you pose to us. And another thing that is quite important that I would like to stress is that this object is something that we need to cope with, is how to deal with misinformation. How can we deal with the erosion of scientific evidence as well? So these things that were raised today, these issues of public health as a concern for health workers, for scientists as well, of the general population that is able to notice that this movement is something that is going to lead to the erosion of health systems, that is also going to lead to mortality, deaths, which is increased by the pandemic. And also I would like to raise this perspective, you brought of thinking about the coming years, that we're actually getting to the end of this pandemic, or are we actually moving to, we're actually going to be living with it for the coming years with new strengths. So from the perspective of having a way of coping with it more directly and efficiently, using non-pharmacological measures, developing new researchers, developing new drugs, developing new vaccines as well, but also looking at the progression of the complications that lead us to think about this monitoring model for the epidemiology of diseases, both for those that stem from the pandemic and for chronic diseases, because they always present complications, especially during the pandemic. So I would like to stress out the importance of what you brought in your presentation about mental health. So mental health for health workers, especially when you look at the sickness and death processes, but also to the new working model, which is also instated for the population in a general way as a home office model. So how they're going to provide support for this health system remotely. And then the need of increasing financial resources to tackle with the pandemic and this current moment that we're experiencing. I would like to thank you for your participation today. And now we're gonna give the floor to anyone who want to ask questions, our participants. And now I'm gonna start with question. And then we can see who's gonna reply to it. But you guys should feel free to make any questions, okay? But the first question, Pedro, just a moment. Can you ask them to stop sharing his screen? Can you stop sharing his screen, Emil? All
Of course.
right.
And
Thank you.
thank you for the very concise summary. Thank you very much, Professor.
Obrigado pela sua excelente explanação.
Thank you for your excellent presentation and for your contribution, which was quite interesting for our international seminar. The first question then that was posed here, what are the key challenges for implementing the intervention strategies for the prevention and the health systems. So whoever want to answer that can do it. We have 4 speakers here, Professor Alex, Professor Marcelo, Professor Maria Elena, and Professor Emil. Who wants to answer it, guys?
Professor Pedro, eu gostaria de começar.
Professor Pedro, I would like to start,
A
okay?
reflexão, eu acho que dos grandes
With
desafios,
this reflection, one of our key challenges, like Maria Elena already said, and Professor Emil said as well, they could answer it better than me to talk about other aspects, but I believe that one of the key aspects is the continuous educational for health workers, educational strategies that are continuous and should come from all spheres that go from the federal level, state level, and city level, among health workers that are working in the public sector, among the Ministry of Health, CONAS, and the state secretaries of health that involve every health worker, but also within the private institutions, within institutions that are ruled by health insurance plans, and most of all with those aspects that go from macro aspects or larger aspects in which this continuous educational matter could be posed, could be done by platform training, but even micro problems within the institutions of the workflow that the institutions themselves could develop this continuous educational strategies for their employees and that they provide this periodically. So now I'm gonna raise the matter of a continuous education, which should be also always be up to date with the best evidence that we have, and that our agencies, either state agencies or federal agencies, should play the role of establishing this throughout the process. Now I'm gonna comment on what Professor Alex just said and talk about the continuous education as well. We want to have this continuous education to strengthen this within this AGIR and this exchange of experience in a daily basis for the worker, this exchange of work processes. This is a way, a very effective way of strengthening the systems, the health systems, and also to train and improve the quality of each health worker's jobs. So I'm also stressing this as an important issue. Thank you, Marcelo. Well, I would also reinstate that Alex is already laughing. Yes, continuous education and permanent education is one of our pillars. So I'm going to quote the case of Brazil. We have a deficit in terms of training, but also in terms of formation and education. So there is a need of assessing how these courses are carried out because we have thousands of medicine, nursery courses. So there is a need of assessing these courses, but also of having these continuous educations in the jobs of permanent education, as Marcelo said. So we have been working with that for individually, but we have to work with that in a system level. We have to work with work conditions that are provided for this population of health workers. So what we notice is that it's quite uneven. So if you look at the north and the southern region of Brazil, you can see that they are quite different. So when you see that in Amazonas, a person needs to get on a boat, to get on a river full of snakes, alligators, or whatever animals that are there, this is a nature thing. On the other hand, we have in Rio de Janeiro an issue of social violence that is much larger than you would have on the northern region. But in the southern region, you have other issues. So you see that this issue of different working conditions, since primary services like health, education, considering like community agents, even get to the tertiary level, which are the hospitals, technological institutes, and we have SUS, which represents 75% of support, health support carried out by Brazil. So we need to look at that. We need to look at working conditions, especially for nurses, which still need to be developed. This is not new. We have identified this before, and not only in Brazil, but also in the world. Many countries go through that. Why are there more candidates to be nurses in the world? Because Europe is hiring nurses from other countries to bring there because of the working conditions. So this is a very important matter. And if you don't think about it, you wouldn't have enough workers, and then consequently, you wouldn't have the mass or the population to be these health workers in Brazil. We have about 60 to 70% of health workers in Brazil that are nurses. And that means there are nursing professions. Out of these, 30% are actually nurses. The remaining are technicians or assistants. So another thing that's important is the political matter, the political strategies to tackling with the pandemic. So this opening with the Ministry of Health so that we can work jointly with the outcomes of how we tackled with the risk of contamination. We noticed that when the Ministry of Health establishes a different strategy of training, is that because this was an important indicator to the training that was carried out. But we know that in the education, we have the simulation, which is quite important, but also it needs to be fed to other strategies.
Bill.
Yes, I don't have much to add. I would wholeheartedly agree with Professor Maria Elena. And yeah, I would also... I'm sorry. I think is it my internet connection? Sorry. Yeah, I would just say that I wholeheartedly
Eu
agree.
escutei o que ele falou.
I'm sorry, I did not understand. It was not translated.
Por favor, tradutores.
Oh, no, there was a technical issue with the other translator, but I'm gonna get back. You can go ahead, Emil.
Okay, thank you very much. Yes, I just wanted to say that I wholeheartedly agree, and I would also stress that it's really important to keep up good working conditions for health workers. It's even a problem in Europe, and this is not. Yeah, you can't solve this without having more financial resources and also better organization. For example, through unions to really fight for better working conditions and rights.
Muito obrigado. Obrigado pela essa primeira rodada, nessa primeira
Thank you so much. Thanks for the first round on that matter. We have another matter that we want to debate with the whole panel. What are the key challenges to cope with the precarization of work and the strengthening of universal health systems? Well, I'm going to start, if you guys allow me. I'm going to be the first one to reply. If anyone wants to start, feel free, but I'm going to say, from the perspective of the Ministry of Health, the key challenge for us to be able to progress with this precarization of the workforce is to integrate the database system so that we're able to do it with more evidence, with a better level of trust, and to be able to understand what we struggle with as well. So we here at the Ministry of Health, we're talking about this number of databases. We're talking at the government, the federal level and the executive branch, especially because of the LGPD, we have serious limitation of access to other ministries, such as the Ministry of Economy, the Ministry of Labor, and even the Ministry of Health in some cases, because we, as Alec said before, we need to be very wary with ethical matters regarding this data. So we have worked a lot of that within CEGET, so we're able to identify the key influences that we're facing so that we're able to deal with the workforce precarization. And another thing that is quite important, and we have been working a lot with, is strengthening researches such as this one from Project AGIR, which is another source. Considering the size of Brazil, the Ministry of Health doesn't have enough people to map all these issues. So to go point per point, but we need support from other institutions that have this expertise, like the School of Nursing from Ribeirão Preto, like Maria Elena is representing here today, but they are quite qualified. And they provide us with the data and the evidence that we need to be able to direct the public criticism and carry out the relevant interventions that we need.
Obrigado, Marcelo.
Eu queria acrescentar, professor Pedro, que diante dessa questão trazida pelo Marcelo, de diagnóstico do que de fato é a precarização, se a gente pensar o termo precarização parece uma coisa genérica, né? Mas quer dizer, o que é a precarização? Em que momento? Então, além do diagnóstico dessa precarização das frentes, mas também que possamos sensibilizar nossos legisladores para que, de fato, possamos transformar essas informações em políticas públicas aplicadas ao Brasil.
And public policies apply to the entire country. Thank you. I would like to say that one of the most important issues is the wages. So wages or salary for the health workers in Brazil, some of their categories receive more than the others, of course, but this is an issue. So wages are an issue. We have this obstacle coming from federal legislators that were within, for instance, the nurses category with a bill that's for approval for years relating to wages. And I'm not talking only about nurses, I'm also talking about doctors who need to have 3 or 4 jobs. So this is the precarization of the workforce. They are being exposed 2 times or 3 times to risk. So you still don't know where the person is more exposed and not. So this, what do we have this as an indicator that is quite important. The conditions of mental health for health workers. So this is noticed because we had an absent rate that was quite high and has a negative consequence to our organization, besides having negative impacts to the worker himself. But today we face more than that. We have absence due to illnesses and mental illnesses, and that make impossible for people to get back to work sometimes. So this needs to be, we need to look at that. We need to create a strategy to cope with that, to control and monitor that. And another issue is working contracts. The working contracts, they are outsourced or are temporary, and this leads the working conditions to be considered precarious. So these are 2 issues that I would like to raise, and that we need to develop strategies, not only in terms of health systems, but also in terms of the law, federal laws, that we need to be able to improve these conditions. Thank you, Professor Maria Elena. I'm not sure if he's here or not. I think he's not here. He had to leave, Professor. I'm sorry. I had a question to make him, but I'm gonna skip it. I'm gonna go to the last question. Faced with the number of deaths of health workers due to the pandemic, what's the take of the speakers on the protection system to the health of health workers? Are they broken? do they need to be reviewed?
Eu começaria respondendo. Acho que o Marcelo abriu o microfone.
Well, I would like to answer it first. Marcelo, do you would like to answer? No, you can go ahead. Pedro, I believe that, matter of fact, we do need to review some things, and like Maria Elena said, she had the sensibility of talking where we should start. This review should start in training. And now I'm going to share one of the experience I had some years ago when I was talking with some students of mine that were on leave a lot of time before the pandemic, and two of them stood out. I went to investigate what they were on leave. They were medical students, and one of the teachers said that they were undergoing an internship in pediatrics, and it's common or regular that students, when undergo pediatric studies, they have some common illnesses and they get on leave. And as an epidemiologist, I was quite shocked with this normalization of sickness or banalization of sickness. So in matter of fact, the scholars have penalized for a lot of time the importance of this process of wearing masks, suited masks. We always had that. We always had this training section in our training, but the way I see it is that it was not integrated into the process. It's the discipline by itself. And then the teacher would teach it, and then we would go to our daily jobs with no greater repercussions. Something quite similar happened to the exposition to blood at the beginning of AIDS, when the health workers starting to have taking care in terms of being contaminated with HIV, AIDS, hepatitis as well, when the AIDS pandemic started. So we tried to sort out more of the issues than we actually thought about how to look at the future of the health worker, of biosafety. So Professor Maria Elena will probably pose other important issues, but the most important thing here is not normalizing things that shouldn't take place, and this is going to start in the university.
Thank you very much, Alex. Well, we fully agree with what Professor Alex said. I believe that this is a matter of strengthening, qualifying the formation, and deal with more value to certain formative processes that all of the graduation has. Maybe we didn't give so much value to some subject and some points of the graduation that I didn't think relevant, but nowadays I think they're more relevant than I could ever imagine. And I agree with what Professor Alex said, and I only think that we have to be careful in the relation of the pandemics and illnesses of healthcare professionals, and the mortality of these healthcare professionals, because we're talking about these exception professions. The more we have precarized work, and the more that we have lack of structure, proper structure in several health institutions, we fight for this to be taken care of as soon as possible. But the pandemic exposed us to several different ways. Like the lack of PPEs in the beginning of the pandemic, that was something frightening, and we couldn't even buy anything for a training. So we were trying to train the healthcare professionals to tackle the pandemic, and we didn't have the access to the instruments and to the PPEs. So I believe that Professor Alex showed in his presentation really well how this curve of mortality decreased after the vaccination process started. So I believe that we need to analyze now with this certain, identifying the points that could be identified, but we have to be careful to relate the happenings of the pandemic with the previous happenings and understand where each spectrum we could place. Yeah. I believe that's it. okay, I agree with Marcelo that we should, but we had severe problems before the pandemics. They were only put to light. They were only made transparent now for a larger part of the population now. For example, Marcelo, in the beginning of the pandemics, we did not have the possibility to purchase material. I'm not talking only about the public services, but also the private services as well. What happened? It neutralized that the professional could use a mask, for example, for 1 month. 1 month they would use the N95 mask when the manufacturer themselves say that it should be used 5 times. 5 times could be during a day because you take it on and off and off. And we continue seeing in Brazil the people adopting the acquisition of a mask per month for the doctors that are in surgeons, for those that are in the front line in the system, for everyone. So it became natural, that issue, that it shouldn't be natural. And remembering when we had in the country those how many accidents did we have and we didn't have. It's not that we didn't have, we continue having, but it's exposed differently. What we should pay attention is some are pertinent to the previous structure, but some are coming brought to light and due to the pandemics, and I think the identification of this is very important because when in the beginning we thought that our protections and our prevention is always done with any patient and any possibility of being infected. The standard precautions, I mean, we saw that was not it. The flows, well, we went beyond that. The flow, the training was completely different. We had a different way of doing it. And now what shows to us that after that, we have to evolve. We have always to have planning and the structured strategies. So we that work with management, what must we do? We must have a strategic planning, and we must leave this planning ready, and everything that comes, we should have at least the basic. But not that, well, we had the basic, but it was inside a different reality. Now we have this reality of the pandemics, and I believe it was disastrous for the whole world, not only for Brazil, but for the whole world. So we could see that as yesterday, Professor Zufu was saying that they created a ventilator in 2 months. Well, if it was not an emergency situation, that would never happen. It would not be possible to happen. So the people decided to face the crisis and the pandemic, and each started helping in their own space. But what I see is that we must have this planning. And a different issue that I also see is that the conditions are being offered in a better way. But we still have to improve it a lot. So we have the capacity building, as I said, the conditions of the environment, and the structural conditions, and the economic conditions as well. And now imagine how much Brazil couldn't have been saving if some flows would be established way there in the beginning. And I see that generally. I'm talking about the tests, for example. You see what happened with the tests. So you see an industry that was millionaire, extremely millionaire due to the tests, and the same, well, the private and the public services don't have tests to make, and we still have a wave which is very important for the professional environment. If you have a person that has a doubt, if you are or not, if you have the symptom or not, so if you put this person in the workplace, or you are contaminating other people, or you are going to lose professionals to work, and that consequently will change all the organization of this the work. That's what I think. I agree with what Marcelo and Alec said. I would like to add this point. And I also would like to mention several of compliments about the presentations and the discussions that were held. So lots of compliments to the media and the medias that are broadcasting. And as we have still 1 minute, I will allow to make another comment and question because it made from the public as well. And just to clarify, this could help us. Well, the national data being presented about COVID among the health workers are available, healthcare workers are available. How can we access those? I'm sorry if I lost this information during the presentation, if I missed it. It's just a doubt. Well, yes, certainly let's thank our participants, and it's very important for the population to know this, and the researchers of other groups and the managers, remembering that this is also a research which the public investment was made, and we have the responsibility to return to the society this knowledge which was produced. So we have we're going to develop to deliver the last bulletins and reports that were developed in the end of 2021, the one that are in addition, and we're going to put them into public, and we're going to bring all of this data which was exploited up to now. And remembering, Professor Pedro, that the project continues for more 4 months, and we're including other regions of Brazil that are already under investigation to close the project with the Brazilian overview as a whole. And soon, besides the scientific publications that were already made, soon we are going to have new scientific publications in which the society will have access to this information. Exactly, Professor Alex. We also have a quantitative data that is extremely interesting, available in Connect SUS app. And those of you that are interested, you can also access some data there for research. And those that are interested in MOH, you have a platform which is eSig, and we have to answer within 30 days. So that might be a good way to request data for research with the Ministry of Health. I just would like to add that in our website of Project AGIR, which is siteusp.agir, you could find all our material. We have 5 bulletins, 5 reports. All of them are already available. 5 bulletins or reports, and we have a guide of orientation for the risk management. It's also available in the website, and it's also available in the site, the questionnaire that it could be used for your services, for the identification of these risks, and also for the management, where we have all the management of classifications of the risk. And remembering, we have some articles that were published, and they are also in the production of the site, sites.usp.br/agir. And we have the risks of infection and this material that Professor Alex presented to us this morning. So we hope that you, if we had some other requests, if you have other requests, please just make contact with us through the website or through our emails. Okay, thank you so much. If you put Projeto AGIR in Google, it's the first hit. Thank you, Marcelo, for remembering this. I will just read a comment here from the chat. Unfortunately, we're already banalizing the protective measures and the neutralization of the illness for COVID. As Professor Maziali just mentioned, the conditions have improved, but we have a lot to improve, and for the awareness of the health professionals. We still have a lot with questionable behavior. Congratulations, everyone, for this morning. And I would like then to close this panel and say that we had a wonderful pleasure to discuss this aspect about the strategies of the Ministry of Health with Project Brasil Conta Comigo, and Professor Maria Elena Marziali bringing important indicators about the morbidity of healthcare workers in the North region with this project that's being developed in several institutions, PAHO and MOH. Professor Alex bringing also data on mortality of the healthcare workers using databases of the North and Northeast region, and Professor Emil from Germany bringing to us a very interesting experience about the cooperation network with effective guidelines to the control of COVID-19. So thank you very much, all of you, all of the participants here this morning, and I pass the word now to Ms. Edamara. Well, the organization of the event would like to congratulate and thank all the members of this panel for the important contributions offered over the topic. And for the final considerations and the closure of the event, we'd like to invite Dr. Krishani Ghosh, the Regional Assessor of Human Resources and Health from PAHO Brazilian office, and Professor Dr. Maria Elena Paluzzi Maziali. With the floor, Dr. Krishani Ghosh. Please, Doctor. Thank you so much, Ida, for this introduction. I would like to thank you all and say good morning to everyone with us on YouTube and on the Nursing School of Ribeirão Preto channel and the Collaborative Center with PAHO, and those that are with us also through the Innovation Portal, which is an initiative of PAHO in relation to the APS strategy. Well, on behalf of Dr. Socorro Gross, representative of PAHO in Brazil, I would like to congratulate all the institutions involved in the organization of this important event, and also Professor Maria Elena Maziali. I'd like to congratulate you and the whole team of researchers in AGIR COVID project, COVID-19, for this wonderful study and this first phase of this wonderful study. And I believe also that it's important to highlight the encouragement that the Ministry of Health gave in relation to this study that investigates the impacts of the COVID-19 pandemics in the healthcare management and the health themes, and the exposure that these health themes are subject to, and also to the costs related to the health systems. I believe that the ministry had an important role during the development of the pandemics in financing and encouraging studies of this nature. And I enjoyed a lot. I'd like to highlight out of all reflections here made about the importance of systems and databases, organized database that would enable this topic that we are discussing due to the health crisis, that it could be investigated based on evidence-based investigations. And that was highlighted yesterday. That was also highlighted today. Intensively, I believe it is a point which is worth to be highlighted. And also highlight the findings of the project. The project has a vast variety of results in this first phase, which can significantly contribute for the planning of actions of our government and the federal government for facing the pandemics and this health crisis. And the importance also on how we just said in the last panel of having a strategy to announce these results being it in the academic world or being it for the organized civil society or for the public general or for the discussion forums together with the healthcare professionals and the technicians. I believe this event is just the kickoff. This is the first action which contributes for this announcement. And let's see what else I was able to take note of. Well, I believe that another point which is important is that the study comes to bring collaboration with this organization of knowledge and this framework of knowledge that WHO is organizing and incentivizing around the expansion of our knowledge about the impact of COVID-19 pandemic. And the study is aligned to this WHO strategy as well. And as now it was said, in the end, we are right in the middle of a second phase of the project with another 4 months of duration of this study. We want already to plan ourselves to have a debate over these results that expanded discussions up to now, and also put ourselves available so we could be assisting in the needs that might arise or come present. And well, I believe that's basically it. I think that we, as an important forwarding of this event, is to have a planning on how to announce and spread these studies and these findings and results, and how we could consider them in the plannings that we're going to have in the future actions. As we really well said, it's not the end of the pandemic yet. The moment that we're going through, well, we still have a question mark about this moment. We don't know yet, and certainly organizing the announcement of these results and the implementation of actions based on these results would help us a lot in this pathway that we have ahead of us. I think that's it. Thank you so much, Professor, for the invitation to be here, and thank you for all the contribution that you and your work group has with Alpes. Paho, thank you. And now we pass the floor to Professor Dr. Maria Elena Maziali. Thank you so much, Shani, for your words, and I and the group feel ourselves very glad and happy to conclude this first phase. And this phase, we had this strong connectivity throughout the whole process with PAHO and the Ministry of Health. I believe this feedback in relation to what the academia and the way that we think and how you think in the ministry and PAHO, it was extremely relevant for us to give this result that could be more pleasant and usable in several ways. So this way of returning through the informatives is not a widely used practice for us in the academia, but it was extremely important for us to be getting used to this format, and I believe that it is coming to those managers way up there in the health services that not lots of times do not have access to this information in a codified way with what we work in our scientific language, but warning that during all the phases we are warning first in relation to the quality of the information and the importance of having scientifically proven information and how we would work with that, and then we could advance until getting to the infection and the mortality. I see that we have now, the ministry will announce our orientation guide. Sorry for that, and we still have this possibility for using the social media because we still have the channel. We also have the channel like Facebook and our internal channels of the project. but we also have via Ministry and PAHO. So I'd like to thank on behalf of the group for all this wonderful collaboration. To the Ministry and PAHO for the funding, otherwise this would not be possible. So, well, because this study is, well, we worked with huge databases, right? And with the whole country now. So I believe that it will bring very important subsidies for the matter of new actions and new strategies. And this participation with academia, I believe it's extremely important also because we work closer to each other. And I also would like to say that this event, when we bring different people talking about these different aspects, in the end, they interact for the reflection. It was very positive. It was very good, not only for us from the academia, but I believe that for us, those of you that were watching us, as the feedbacks that I could see, where we enabled the reflection about this topic. And that was our main objective of this webinar, international webinar, expanding or deepening the debate or discussion on how to tackle the pandemic COVID-19 in Brazil and the actions of all participants here as well. So I see that, yes, it's the beginning, it's the kickoff of a large announcement that we must have so we could get to those that are alone on the other end, for example, in Amazonas state, Roraima state, I don't know where, but so they could be absorbing this knowledge that was produced as well. So I'd like to thank you all, the whole team, the project AGIR team that lean on this project throughout the whole year. And I'd like to thank the team from the nursing school of Ribeirão Preto and the technicians we would have here, Idamar, we have William, we have Rodrigo, and lots of other ones that helped us in being and making this happen. Okay, so thank you very much to all of you, and thank you for all the public participating with questions and also watching us, and all our colleagues and the guests that participated here with us via Zoom and YouTube channel. So I declare our seminar closed, considering the possibility of other seminars as well. Thank you so much, everyone. I wish you all a good afternoon.